for having me today. I really appreciate it. All right, if we can go to the next slide. We're going to talk about headaches today. So we're going to talk about headache classification for migraine, briefly review the pathophysiology of migraine, review current, acute, and preventive medications for migraine, review a few devices, and then some other therapy things such as behavioral cognitive therapies and biofeedback. Next. So epidemiology, so the prevalence of migraine is quite high, 11 to 12% worldwide. And as you can see, the female to male predominance is 3-to-1. That's a pretty big chunk of my practice. And it is the second leading cause of disability worldwide. It accounts for up to 3% of emergency room visits. And then if you look at the economic burden, it is considerably higher with migraine versus those without migraine. And then if you look at that from a bigger scale and think about what are the age ranges of the people who are typically involved in migraine headaches, you're looking at those 20s to 40s range. And those folks are going to be the ones missing the most activities of daily living, missing their kids' practices, missing their niece and nephew's birthday party, missing work, missing all the things that are important to them. So when you look at the financial burden, that's one thing. But if you look at the quality of life and those days of missed life and disability, that's where things get really serious. Next slide. So we're going to briefly go through the International Classification of Headache Disorders, so ICHD-3 for those familiar. So migraine without aura, so at least 5 attacks fulfilling the following criteria. It should last around 4 to 72 hours. It should have 2 of the following characteristics. So it's typically unilateral, but it can be both sides of the head, pulsating or throbbing quality, moderate to severe intensity, and aggravations by or avoidance of routine physical activity. During the headache, at least one of the following: nausea and or vomiting, and then light and sound sensitivity. Next. Migraine with aura is similar to the prior, except you have fully reversible aura symptoms. Typically, those are going to be visual. That's the most common that everyone seems to know about. But you can also have others, including sensory changes, speech or language changes, and then even more serious with motor, brainstem, and retinal features. Typically, we would like to have at least 3 of the following. We want the aura to spread gradually over about 5 minutes rather than coming on suddenly, having 2 or more aura symptoms in succession, and then each individual aura symptom we'd like to be 5 to 60 minutes. There are some auras that are persistent and they can be longer than 60 minutes, even lasting days, but that's a whole different ballgame, and we do a big workup on that because we worry about other causes. So anytime you have something that goes outside of this, it's kind of a red flag for us. And then typically within 60 minutes, you should have a headache after that time. Next. So chronic migraine is another one that we really need to talk about because this is something that definitely affects women more than men, and we deal with a lot. So this is a headache, and it can be either migraine-like or tension type on greater than 15 days per month for greater than 3 months, fulfilling the following. So the real key is for greater than 8 days of those, they are migrainous type of headaches. And so typically these can be relieved by a tryptophan or ergo derivative. And we'll talk about that a little bit later. Those guidelines have not been updated just yet, but may need to include GPANs, which we'll discuss today. Next. So status migrainosus, this is one that a lot of you who work in the inpatient world have seen, and that's a headache attack fulfilling the following. It can occur in a patient with migraine or aura and has typical of previous attacks, except for this duration and severity is significantly worse. And it typically is not as commonly able to abort on the outpatient setting. And it is often caused by medication overuse headache, meaning using your as needed medications more than recommended. Next. So this is important, the 4 phases of a migraine headache. People always think about the pain, and we don't think about all the other things that go along with the headache. So with a migraine, we typically have a prodrome, and this can actually happen even 1 to 3 days before your headache starts. Some things that people will find is they will have increased muscle stiffness, increased urination and yawning, nausea, fatigue. And there was a giant study done that was really well done that showed that irritability, neck pain, trouble sleeping, those are all things that happen very early in people who are very attuned with their body. And then the auras can come on, as we talked about, for 5 to 60 minutes. And then that really severe headache. And the things I want to point out there is you can also get that speech change. And some people just describe a cognitive fog or fatigue, where they just don't feel as sharp as they normally are, feel like things come to them a little bit harder than normal. And then dizziness is also really common, and that can either be vertigo or just a feeling of kind of on a boat rocking. And then the postdrome can last again another 1 to 2 days. So a lot of folks like to refer to this as their migraine hangover. But again, it's that being unable to concentrate, mood changes, fatigue, and just not feeling well overall. Very rarely, some people can have the opposite where they feel more euphoric, but that is not the typical that we hear. Next slide. So I'm going to briefly stay on this page because no one loves these complex pages, but I want to point this page out because if you look at all the areas of the brain that are included in migraine, I think it's really pretty astonishing. So we used to think that migraine was just a headache, right? Well, now we've learned it completely is not just a headache. If you look at all the receptors, the serotonin, the dopamine, the norepinephrine, and all the different places that are included in headache, it really affects the entire brain. Definitely starts in that brainstem, but then it spreads to everything. And then we end up with that cortical spreading depression at the end, which really takes it to the next level. I think one of the things that's really interesting to point out here is the term allodynia. So people will talk about their hair hurting, or it hurts to even brush my hair or touch my scalp. And those are real things. And they're coming from a couple different places, but obviously our thalamus and our medulla, those are some places that we have a lot of those triggers that are going to affect that. So very common symptom, and something to make sure your patients know they're not just in their head. This is a real migraine phenomenon. Next. So again, migraine is complex and it's neurally driven. So we just looked at that. There are cortical and subcortical regions and modulatory centers involved. There are monoaminergic and peptidergic pathways intertwined, and that's where some of our drugs are going to come into effect later. And the vasculature is intimately involved, yet we've now found that vasoconstriction is not required to improve symptoms based on some of our new medications. Next. So this is where I start. So everyone's like, how do you even talk to a headache patient? So for me, history matters the most. So getting that criteria, getting those questions are very important. But then what are all the other things I need to think about? One of the biggest ones is checking out the medication list. A lot of the medications we prescribe, particularly for women, can cause headaches. So look at the acne medications you're prescribing your patients. Look at any of the hormonal changes that you're prescribing for patients, whether that's birth control, hormone replacement therapy. Those are all going to be things that we need to think about. And then typically screening for sleep apnea is really important. You can use an Epworth sleepiness scale or a stop bang, but it's not necessary. You can just ask your patient sleep-related questions. And a big one is screening for depression and anxiety, because we know that chronic pain and chronic headaches go hand in hand with depression and anxiety. And it's really frustrating to hear some of the literature in the past say that depression and anxiety is why people have migraines. Turns out that's not the case. It's a vicious cycle that both are intertwined. So treating one without the other is really not very useful. And then definitely ask about recreational alcohol and drug use, as we know some of those things can contribute. Family history of migraine is huge, particularly with some of our newer genetic information that we've been getting. So we are now finding more of our hemiplegic migraines, and some of our microvascular changes with migraines can be related to certain genetic factors and genes. And so that's going to be important as time goes on. Having yearly eye exams, particularly to check for things like glaucoma or papilledema, is really important. And then, like we talked about, those hormone changes in females or transgender populations. So people going through IVF are going to have significant headache swings, different birth controls, and again, our transgender with hormone changes are going to cause those same problems. Next slide. All right, so Snoop 10. So this is kind of an updated version, and there are lots of these out there, but I just wanted to post this for red flags, and this can be available to you later, but just things to watch for. If you have someone who has a really significant change in their headache type, that's something to start being aware of. Like if you're someone who's had the same migraine for 20 years and all of a sudden something feels very different, that's usually going to be a sign that we need to do some further workup. Any focal neurologic signs, any systemic symptoms like fevers, chills, night sweats, any thunderclap headache, so any headache that comes on very quickly. So we talked about aura symptoms should come on over 5 minutes. Headaches should also kind of do that. So if anything's happening in a more rapid succession, we recommend getting evaluated for that. And then postural changes. So that's something I think that has become more and more valued in our neurologic world, because we're seeing a lot more cerebrospinal fluid leaks than we ever have before. And I think that's because we're finding them. So if you have someone who has significant postural headaches, that's time to send them to a neurologist for a better workup for sure. All right, next slide. So imaging recommendations, I'm not going to spend a lot of time here, but I think it's always important because everyone says, well, when should I get an MRI or a CT? So most of our imaging recommendations are level C. The American Headache Society does recommend MRI over CT when available and possible. And so these are some of the reasons you would do it. If you have, again, changes, those are going to be your biggest one. If you have an aura, but you don't actually have the headache, we want to make sure we're treating the right thing before we move forward with that. And so if you have some of these things going on and you're just not quite sure, that's an appropriate time to send the patient on to a neurologist as well if you're uncomfortable with what to do with the imaging. Next. So we're going to transition to some treatment options now. So I put some little jokes in here from time to time. So we can go to the next slide. Okay, so there are multiple treatment approaches. So lifestyle modifications, acute treatments, prevention medications, devices and neuromodulation, cognitive behavioral therapy, counseling, and biofeedback. And it really takes all of the above. Next. So we'll start with some lifestyle modifications. Next. So this one's the hard one. So everyone wants a pill. We all want an easy way out. We're all busy. We don't have time to do all of this. Unfortunately, with migraine, we really have to do all the things. So hydration, we always tell people, put a lot of water in your body. It's going to help you. I didn't have great statistical significance for that, but on the studies, but we do know that at least 60 ounces of water per day is very helpful. Caffeine is not too much, not too little. So be consistent is what I tell my patients. There is some data to support that. If you go with no caffeine, it has to be pretty strict because otherwise you're going to induce a headache if you have any caffeine and then withdraw from it. Sleep, again, we talked about that a little bit. Alcohol, oxidative stress impairs cerebral autoregulation, which is going to lead to more headaches. Diet, this one's tough because I kind of skipped obesity because I wanted to tie these two together. So there is some data potentially a BMI greater than 30 may have associated increased frequency and severity of episodic migraine attacks. And so what's interesting is that we talk about diet a lot and we talk about what are our triggers and what do we do. And I've had people do lots of food diaries and really try to nail these things down. I've had a lot of folks go on special diets for migraine, and I'll tell you, most of those things don't work. What really works is eating a balanced diet, staying away from the processed carbs, and staying away from the white sugars. So a lot of those things do have a little bit more evidence behind them. But in general, if you find a trigger, avoid it. I have a whole list that I hand my patients and I say, go through it. If you see something, you're like, okay, that's definitely one for me. Great. But I think it's very difficult to manage our diets around migraine. But I think doing a healthy diet is the important thing, and exercising is always good. Next slide. So we'll move into acute treatments. Next slide. So I've got some evidence-based information here. So we probably all know about triptans. Some of us may know about DHE, and then we're going to spend some time on the newer drugs, the calcitonin gene-related peptide receptor antagonists. We're also going to spend some time on lasmiditan, which is newer and probably not as well heard about. But the old tried and true are on there, the NSAIDs. So we still say those work pretty well. And then on the IV magnesium, I always like to put that in there because we use that a lot in the outpatient world and inpatient world. And there is low evidence for it. But when you look at it over the continuum, it's actually really safe. And it does help significantly with the aura for a lot of folks if aura is their predominant symptom. Next slide. So to talk a little bit, we're going to briefly spend some time on triptans because everyone is aware of those, I'm sure. So it's a selective serotonin receptor antagonist. I'll point out it works on the 5-HT1B1D receptor, and that's going to be important when we start talking about lasmiditan a little bit later. If you look at the data, it's not so great. So triptans produce pain freedom about 37 to 50% of the time compared to 11% in placebo. We have some people that triptans are their gold and they would never get rid of them. And some people, they just don't work as well. I always like to tell people about the triptan side effect. I call it the anything from here up. So basically shoulders up, you can get numbness and tingling, tightness in your muscles, feel a little bit dizzy or lightheaded. Some people just feel like they're yawning even more than they were before, just feel a little tired. All that typically lasts somewhere between 15 to 60 minutes, and the headache should go away as those symptoms go away. And again, your contraindications, any history of coronary artery disease or ischemic stroke, you should not be using this class of medications. Next slide. So again, we kind of talked about that receptor, so the 5-HT1B and 1D. So if you look at that blown up picture, you can see that those are around your blood vessels, hence why these cause vasoconstriction, and hence why you don't want to use them in someone with coronary artery disease or history of ischemic stroke. So just kind of pay attention to that for later. All right, next slide. So this is a list of the acute treatment for triptans. The ones I'm going to point out to you are frovatriptan and naratriptan. All the other ones you can repeat after 2 hours. Those two need to be 4 hours. And so that's something to be aware of. And those two are going to work best in menstrual migraine as well as zolmitriptan, possibly because of their half-life. And some of the ways that we'll dose those is we can actually dose those 1 or 2 days before a menstrual cycle starts, and then continue that through menses for 4 to 5 days in a row, and that will typically help prevent and treat the migraines during that time frame. Next slide. There we go. So another acute treatment is DHE. So this one is non-selective. It has multiple ways to be given. Again, coronary disease, vascular risk factors, we don't want to give it. But again, the pain relief was a little bit higher in this compared to placebo. And then the most bothersome symptom, which is MBS there, freedom at 2 hours. And most of the studies now are going to be reporting the MBS, the most bothersome symptom as well. So that's kind of the newer drug classes look at that. No triptans to be utilized within 24 hours of this. This is kind of a novel way to give this medication compared to what we've had previously. And there's a brand new drug that just came out, which is going to be a DHE in another form as well, and just got FDA approval. So that one will be one next talk we can add in, but we can go to the next slide for now. So acute treatment on gepants. This is where the newer literature comes in. So rimegepant is a 75 milligram daily as needed dose, and it typically provided some relief at 2 hours. But again, all the data on these are not wonderful. So 21.2 versus 10.9 at placebo. So it does work. It's just not that great. And that's the unfortunate part with all of our migraine therapies. None of them are 100%. And so the big important thing here is that if you are on a CYP3A4 inhibitor drug, you should use this every 48 hours instead of every 24 hours. And then the big thing that has happened recently is the entire class got an update of Raynaud's and hypertension. So that is something new to be aware of for anyone who's been utilizing these drugs. And so there are different ways that we can approach that. So we are not saying you can't have it if you have hypertension or Raynaud's. We're just saying we need you to monitor your blood pressure, monitor for that Raynaud's to worsen. If you develop any ulcers on the fingers or toes, we're going to need to stop that medication. Next slide. So ubrogepant is the other. It comes in a 50 milligram and 100 milligram. I included a picture of this one because whereas Nurtec is dissolving tablet, Ubrelvy is a very large pill, but it's actually incredibly easy to swallow if you talk to the patients. So it is big. It looks daunting when you have a migraine and you're nauseated and you can't imagine doing it. Some people are a little hesitant, but it does work quite well. Very similar data on its 21.2% pain freedom at 2 hours compared to placebo. And again, there's a little dose adjustment there if you're on certain medications. Next slide. So Vegepant is the same class. It is going to be a nasal spray. I will tell you with this one, the biggest complaint we get is the terrible taste in the mouth after being administered, as well as a lot of burning in the throat. A couple of things you can do for your patients is have them bend their head forward and put it in without inhaling up. It gives a little bit better direction and doesn't cause as much of the postnasal drip. Next slide. So lasmiditan, this is the one I wanted to focus on just for a moment with the 5-HT1F receptor agonist. So we talked a little bit about 5-HT1B and 1D, and those are on those dural blood vessels. This one does not have the same vasoconstrictive effects because it's on the 5-HT1F, which is more in the brainstem focus. So it's just something to be aware of. But unfortunately, this one has a no driving for 8 hours after a dose rule because of dizziness and somnolence. And so that's something to be aware of with your patients, that if they need this, this is going to be, in my mind, my rescue for a patient who doesn't want to go to the ER. They're going to be able to take this then and go to bed and hopefully make it through the rest of that day. Next slide. And so this is an important one in what we're talking about today, treatment in pregnancy and lactation, because it's lacking. So I have some of the most effective and first line and second line and what we could potentially use. The ones I'll point out is, as everyone worries a lot about doing triptans in pregnancy, there is some data that triptans are likely okay. Sumatriptan is the most studied, particularly in the second trimester, early trimester. There are a few reports of it causing increased risk of postpartum hemorrhage if given within 24 hours of delivery. So I'll often have patients stop at 2 to 3 weeks before their due date. I think that's a low risk, but it's still easy to do at that point. And then the gepants, ubrogepant and rimegepant, this has not been updated since then. This is data from last year. And so ubrogepant now has a small case file where it has also been shown to have minimal exposure in breast milk and is also safe in lactation now. Next slide. So prevention medications. So again, we've talked a lot about placebo so far. So we'll go to the next slide. So prevention can be offered based on the patient. So I base it on the severity of disability and the patient's choice. So we talk about it and we make a decision together, but these are the true guidelines. But the truth is it's really patient dependent. Next slide. So reality of prevention, people aren't good at it. So people will often stop their prevention medication because they felt like it didn't work. So I think setting the stage of saying we need to be on this for at least 90 days if we're going to try it, unless you absolutely have terrible side effects, at the maximum tolerated dose. So you're going to feel like a guinea pig because that's what everyone tells me. Yes, you are. We're going to keep pumping that dose up slowly, slowly, slowly until you can't tolerate anymore. And it seems just terrible that we do it that way. But that's the best way to make sure we're getting the maximum tolerated dose and doing that trial for at least 90 days to get a good trial of the medication. Because what we find is people are like, oh, I've tried 16 different medications, but when you get down to it, they tried it for 2 weeks and it didn't work, so they stopped it and tried something else. And so some of this information is hard to gather because we don't know how well they work because people aren't staying on them. Next slide. So over the counter, a lot of people like over the counter options. I think these are fantastic. Butterbur is level A evidence, but it does have some risk for liver damage and lung toxicity if the patients are not using a quote purified form, and those are quite expensive to get. Magnesium is great, 400 to 600 milligrams daily, watch for diarrhea. Feverfew, we used to do it all the time. Turns out it doesn't work super well. Riboflavin had a possible benefit, but then there was another poster update at the American Academy of Neurology a few years ago that showed that it was probably more beneficial than we thought. And then CoQ10 is an easy one. So these are all cheap, over the counter, and quite safe to utilize for people who don't want to be on prescription medications. Next slide. So again, these are some of your prevention meds that you are all familiar with by now. The ones I want to point out that got added recently are candesartan and lisinopril. So those may be something you're not as familiar with. And topiramate is falling out of favor in our pregnancy class of patients, and divalproex. So we typically don't use those in people of childbearing age unless we have a very distinct conversation with them. Next slide. So other prevention methods, Botox, a lot of people are familiar with Botox. So 31 injections at the sites you see there every 12 weeks. Again, realistic expectations, 8 to 9 fewer headache days per month. So 6 fewer days with placebo. But again, that builds over time. And I do feel that continues to do better. And we do recommend at least 2 series. Next slide. And again, we're talking about those calcitonin gene related peptides, and those are going to work on the dilation of cerebral and dural blood vessels, release of inflammatory mediators, and pain transmission. Next slide. So prevention with CGRPs, I put a slide there, and the important part is to look at those elimination half-lives. We'll talk about that next slide. So aranumab, so Amavig, has a self-injector pen or a pre-filled syringe. It comes in 70 and 140 milligrams. And you'll see on there, this is where those important questions come for women. We do not use this for 5 months prior to conception. You need to be off of this medication due to that extended half-life. So this is where a lot of the counseling is going to come in. And that's going to be true for all these injectables and the IV Vyepti. And so I always ask my patients, what are your pregnancy plans over the next few years? What are your plans for contraception? Like what are we doing with our life? And then adverse effects with this one, the biggest one were constipation and significant hypertension for even causing some hospitalizations and press. And there have been a few bowel obstructions requiring surgery. So this is one that if you have someone with significant constipation or high blood pressure, you might put lower on your list. Next slide. So fremanezumab, which is a Jovi, comes again in the 225 monthly or 675 every 3 months. It hits the ligand. So this one's different than Amavig a little bit. And again, that same 5 months prior to conception, we need to be off that. Again, data on these are rough, 4.3 to 3.1. But what we find is people who respond are just super responders and do amazingly well with these. Next slide. And then galcanezumab, which is Emgality, comes with the loading dose, and then you go to 120 milligrams after. And I will say that I think the loading dose is really helpful. The negative with this one is it's in a citrate base, and so it burns terribly when injected. So we have a lot of people who don't love that, but we set it out for 30 minutes, get it to room temperature, use ice on the site before injecting if you need to, and then clear Benadryl gel after helps with that hypersensitivity injection site reaction for all of these. Next slide. And then Vyepti is the infusion. Got to go through a lot of steps for this. So typically this is going to be the neurologist prescribing this, but it's also indicated for medication overuse headache. Next slide. And then we've got our G-pants that are for prevention. So Nurtec we talked about for acute headaches. It's also a prevention method. And then Qulipta, which is the newer one that is a daily medication. And I've got, again, the hypertension and Raynaud's updates on those. And that's about all that we've really seen different with those. Constipation with Qulipta is around 7%, usually well tolerated with some Miralax. Next slide. So devices and neuromodulation are a big area where we're moving forward with our trials. Next slide. So this is just a quick slide from Continuum showing the different types of stimulation. I'll go through a few of the stimulators. I will point out that a lot of these are FDA approved due to safety and not necessarily efficacy. So that's just something to remember on all of these. Next slide. So the Cephally device is a transcutaneous electrical stimulation to the trigeminal nerve. It comes with two modes. So you've got an acute mode that's 60 minutes. So when you have a migraine, you can put it on, and a prevention mode of 20 minutes daily. The study that came out of Brazil on this showed that the best was if you used it at the exact same time every day and were very consistent with it rather than doing a random 20 minutes throughout the day. But very safe, very easy to use. Next slide. The GammaCore device is a stimulator to the vagal nerve. It's external stimulator. Again, it has variable relief there, as you can see below, but it again is relatively safe as long as someone doesn't have a history of vasovagal syncope or bradycardia. This is one that I find people tend to do well with at home, but these are incredibly expensive and insurance does not cover them. So it is very rare that I get a patient to be able to continue on them. Next slide. Nerivio device, this one has probably the best marketing I've ever seen. I'm not so sure that it has the best results. You get 12 treatments of 45 minutes each. Its claim to fame is that it hits the descending pain inhibition of C fibers. It is controlled by your smartphone, very easy to use, even if you continue working with having it on. So it's something that we use a lot more in children. It is something that we can use very safely in almost any patient. Next slide. We have the Relivion MG. So this one hits the trigeminal and occipital nerves and stimulates both. Bluetooth wired, it collects data about your migraine, about your treatments, how you respond. And it's, again, fairly safe and easy to use. Anything electrical in the body, we want to avoid a lot of these things. I didn't include that on those slides, but if you're sharing electrical impulses, check with the cardiologist, check with your deep brain stimulators, those things before you utilize these. Next slide. And then finally, this is one that we will use in pregnancy. Sometimes this is the sphenocath. It's a sphenopalatine ganglion block, and we use lidocaine typically with these. They may be performed under fluoroscopy, but we can do them without that during pregnancy, and it's quite safe to do. So it's something we utilize a lot. Next slide. All right, and finally, our last couple slides are on cognitive behavioral therapy, counseling, and biofeedback. Next slide. Again, things that are not easy, right? We like the pills. We don't like the lifestyle and CBT. But we do find that in continued cognitive behavioral therapy and doing some mindfulness meditation, we do get reduced frequency and severity of migraines and stress and disability caused by migraines. So it is helpful if you're consistent with it. The problem is getting it covered and found in the city is always hard. Next slide. Pain psychology, counseling, and meditation. We just don't have great evidence on pain psychology because we don't have a lot of them in town, and it makes it very difficult, but we do know combining that with typical migraine treatments is going to be very helpful. And meditation, always a good thing to do. There are lots of apps that are out there for mindful meditation, and they do work as long as you're consistent with them at all times. Next slide. All right, and there's my contact information. I think we're right on time, so we should be good there, and I will be available for questions. Thank you.